Good evening to everyone. Today's topic is about drug interactions in anesthesia. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, and our institute, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Pondicherry. All my slides are available in pain-free Partha and around 85 YouTube videos in pain-free Partha. So whenever I started working on this topic and go to the internet to see so many articles, all these articles were having graphs like this. So I don't know whether we can understand these graphs. We have to go really into that. So I'm not going into that. For me, it is simple. Everyone knows second gas effect. Okay, nitrous oxide will increase halogen uptake. Nitrous oxide will increase sevoflurane uptake. This is a drug interaction. One drug changes the absorption. What is absorption? Pharmacokinetics of another drug. So this is a drug interaction for me. Now let us in a proper way. What is a drug interaction? An interaction is said to occur when the effect of one drug are changed with the presence of another drug. That's all. The effect of one drug is changed with the other drug. That is what is interaction. Why should we know about this? Because physicians don't read a skin doctor. I don't know whether they wrote drug interactions or not. But anesthetists have to read about so many things like that. It includes drug interactions. We combine drugs because anesthesia is triangle. Hypnosis, analgesia, muscle relaxation. They included blockade of autonomic reflexes. So we may need to combine drugs. Now, if you see the number of drugs administered and the possibility of adverse reactions, if you have 10, it is around percentage is 10. If you have 15, the percentage is so much. Similarly, the mortality rate. Similarly, the inpatient rate. Drugs are more, your hospital rates are more. Now, what are the types of interactions? Pharmaceutical, pharmacokinetic, and pharmacodynamic. What is that? Pharmaceutical, simple. Pharmaceutical, pharmacokinetic, and pharmacodynamic. In the pharmacodynamic, it may be additive, antagonistic, synergistic, etc. We will come to it later. There is one thing called inverse agonist. Now, if you see, this is the agonist. So, agonist means it sits into the receptor plus the intrinsic effect. Whatever be the intrinsic effect, potassium channel opening. It is an intrinsic effect. It sits on the receptor and opens the potassium channel. That is what it is done. What does the antagonistic do? What does it do is it sits and doesn't do this property of opening the thing. What does the inverse agonist do? It closes more and more of the receptor. It doesn't open. It closes more receptors, potassium channels. So, agonist, antagonist, and inverse agonist. Now we will go to definitions. What is a pharmaceutical interaction? It is a chemical or physical, both, that occurs before a drug is administered or absorbed systematically. Patient is administered before or it gets absorbed before it. That is what is called a pharmaceutical. What is pharmacokinetic? When one drug alters the absorption, distribution, metabolism, elimination. What are those three, four things? Pharmacokinetic, absorption, distribution, pharmacokinetics, metabolism, pharmacokinetics, elimination, pharmacokinetics. What is the pharmacodynamic interaction? It occurs by changing the sensitivity of the receptor, changes the tissue to the drug. All these things is pharmacodynamic. Now, WTG modern ether when you give, it produces sedation. It produces hypnosis or sedation. It produces some pain relief. It produces muscle relaxation. So, no more drugs are given. Now, you see, patients don't want mass injection. They want to be pain-free. They want to be quick recovery. No delirium. no vomiting. So you may need to give injection of thiopentone, fentanyl. You may need to sevoflurane. You may need to add some no delirium. We may need to add some dexmedetomidine and some ondansetron. So now see the number of drugs for the same achieved by the good. Combination therapy can reduce toxicity. That is why it's given. We give beta blockers and then add amlodipine. And you just works. Now, pharmaceutical interaction. We'll go to step one. What is that? So before patients is getting administered into the body, for our interactions or changes in the physical chemical structure of a second drug in the same solution in the syringe or bag or one infusion systems. Now you see thiopentone and scoline in the IV line. This is going to be white precipitate. Sometimes you do pentazocine and taxine, they'll get precipitate. I can see many of the hypotensive episodes just after delivery, maybe due to your giving of the antibiotic in the same syringe where we have given pethidine or something. So that is, you can see in the three-way small white dots like structures, which I think causes hypotension. It is not proved. So I am very particular about flushing all these antibiotics and clearing things before administering the narcotics. Bupivacaine and sodavecca, adrenaline and sodavecca. Wait here. Now this is what I used long time. Glyco, Torapepin, pentazocine, diazepam, and ketamine. This combination I have given thousands. But there is only one book which tells long back in 93. I think it is Wiley's second edition or something like that. It tells this is safe. If you add diazepam and it becomes slightly white, there is no reduction in the activity of diazepam or pentazocine or fentanyl. That is what is given in long back, but there is no evidence now. I have used in more than some 12, 13,000 cases. Now, heparin and hydrocortisone, activation, inactivation of heparin. See, whenever we are giving, we see because we give heparin and then we give hydrocortisone. Hydrocortisone is an emergency drug. We don't know what is what. So we give hydrocortisone and make heparin ineffective. Inhalation agents, older anesthetists, younger ones. Older anesthetists may say trilene and soda lime, younger ones may say sevoflurane and soda lime. Now, what has happened? Sevoflurane into the soda lime creates compound A. That is a drug interaction. But what is happening? This is before the patient being administered at all. So it becomes a pharmaceutical interaction. Sevoflurane and soda lime. Now we know what is a pharmaceutical. If you add lidocaine and soda bicarb, then if you add bupivacaine, soda bicarb, or if you add thio and scoline, all these things are pharmaceutical drug interactions. Now I will go to pharmacokinetic. In the pharmacokinetic, there is absorption, distribution, metabolism, elimination. Okay, now go to absorption. If you give morphine, if you give morphine and the blood is level is there, when the patient wakes up, if you give paracetamol, it remains action of paracetamol. The paracetamol is not that effective. If you give anesthesia, paracetamol oral is not safe. I have already told second gas effect is absorption. Adrenaline and local anesthetics is also absorption. Okay. Now if you give an adrenaline and local anesthetics, the local anesthetics absorption is delayed. This is an absorption level pharmacokinetic interaction of lignocaine and adrenaline. Distribution, possible depression of cardiac function, vasodilation, propofol. This is not much discussed, but I always think about this problem. So we say, if you say agent, if you switch on the agent, we are very worried about vessel rich group, vessel poor group, vessel median group and all. I don't know what all these things will happen when you are given 150 milligrams of propofol by creating a vasodilatation. So this and that is slightly questionable. There is something called fever produced by thyrotoxicosis and aspirin should be avoided to decrease fever because it increases free T3 and T4 levels. So aspirin fever therapeutics is because it interacts at the level of plasma proteins, it interacts at the level of distribution in the pharmacokinetic level. Yes, I always used to wonder about the cytochrome P450 when I was in Tanjore Medical College undergraduate. I think if you remove this one word from Chatoskar book of pharmacotherapy, it will become like this. So much of cytochrome P450, erythromycin, warfarin, all these gerifilin or theophylline, all these drugs, cytochrome P450, drug interactions, especially with opioids, benzodiazepines, and agents. See here, warfarin and barbiturates, oral contraceptive, rifampicin, prednisolone, and anticonvulsants. We all know neostigmine and scoline, but we also know organophosphorus and scoline because organophosphorus is full-fledged, and if we give scoline, the patient may not breathe for another 1 day. So sometimes we give like that because organophosphorus is very bad case. He may need ventilation for 5 days. So give full dose of scoline, let him be paralyzed for 3-4 days like that. People used to give those days scoline in organophosphorus, but beware, no scoline in OPC. MA1 inhibitors, everything is a separate subject. MAV inhibitors, pethidine, dangerous combination, serotonin syndromes, hepatic biotransformations. Now, hepatic blood flow is decreased by agents. That is what we know. Okay? Agents decrease hepatic blood flow. We have certain drugs like lignocaine and propofol, which have high extraction ratios. What does it mean? The liver is there. 10 milligram goes to the liver. The whole 10 milligram is extracted by the liver. That means it is high. Now 10 milligram of diazepam is given, only 3 milligram is out. So that is low extraction. So low extraction drugs, if you decrease hepatic flow, not much of, but high extraction ratios, if you decrease hepatic blood flow, then there may be problems. So agents, lignocaine and propranolol. Yes, intermediate steroids, everyone knows. Now we will go to drug elimination. We know absorption, distribution. Now we go to elimination. Cation systems eliminate. See here, the same system eliminates atropine, isopolyne, neostigmine, and naphthalene. So atropine and neostigmine, same system eliminates. It has been a teaching for so many decades that make the urine alkaline. Barbiturates will go fast in the urine. Forced alkaline genesis of barbiturate coma. So this is about elimination drug interaction between alkalinization of urine by soda bicarb and elimination of barbiturates. Now we have finished pharmacokinetics, pharmaceutical pharmacokinetics, absorptions, distribution, elimination levels. Pharmacodynamic is antagonistic, additive, and synergistic. 1 plus 1 is equal to 3 is synergistic. 1 plus 1 is equal to 2 is additive. If you have rocuronium and mecuronium, nitrous oxide with volatile anesthetics is additive. 2 benzodiazepines are additive. Identical mechanism, same GABA mechanisms. If you have drugs, it is going to be the same. But sometimes you have potentiation of opioids by NSAIDs. You have potentiation of non-depolarizers by various volatile agents. If you give sevoflurane, your relaxant need is less. Supra-additive interaction between rocuronium and mecuronium, additive interaction. Rocuronium and atropurium may be supra-additive interaction because this is benzoyl-isoquinoline, this is aminosteroid. Which is benzoyl-isoquinoline? Tracurium. Which is aminosteroid? Cronius. What are antagonistic drug reactions? Neostigmine, naloxone, flomazine. An antagonistic drug interaction between scoline and non-depolarizers also. Sometimes if you give scoline intubate, then maintain with non-depolarizer. Give the non-depolarizer before the scoline goes, your action may not be there. There is one more tricky situation. Because if you add buterphenol, that comes as some company now puts it with midazolam, the sedation is increased by midazolam. The midazolam is going to cause this much of sedation. Okay? Now, if you add buterphenol, sedation is going to be more, but amnesic effect is going to be less. This one same combination, buterphenol and midazolam. In one action, it may be more, and one action, it may be antagonistic. Amnesic antagonist and sedation additive. Now you go to clinical scenarios. Rapid acting beta agonist. We give inhaled salbutamol, nebulized salbutamol with ipratropium, and then give IV theophylline. Yes, we are in the risk of tachyarrhythmias and ectopic rhythms in the heart. Patients with bronchospasm. Albuterol is nothing but salbutamol. In UK books, it is written like that. Premature labor. Sometimes we give nifedipine, sometimes we give retardine. All these things produce tachyarrhythmias. Tricyclic antidepressants minimizes the use of pancuronium, halothane, ketamine, prone for arrhythmias. TCATs can also produce hypotension. Beware, I have one case where after the spinal, there is persistent hypotension in a routine case. So I started doing ephedrine. I don't know where is it going. Then I went to the asked the patient attenders and they give a list of TCATs patient is taking. So beware. They may think that this is not necessary for anesthesia purpose. There is one more warning which I want to give when you start anesthetizing a college student or a high school student, because there is a lot of tobacco, cool sip, so many, they cause a lot of autonomic dysfunction. And even when they put the tube in a normal, healthy 20-year-old male, the BP rises to 180, the heart rate goes up to 110, 120 and all. Yes, go into the details of substance abuse. Now, pharmacodynamic interactions affecting analgesia, propofol, and midazolam. For thiopentone, midazolam, 1.8 times more potent. I want to put the graph like this. Here is the green map. No movement. Plasma fentanyl concentration is increased. Now you see isoflurane concentration needed for no movement is decreased. Decreased match of agents, IV lignocaine, clonidine, and midazolam. So if you give IV lignocaine, that's what people start using now, lignocaine infusion. Clonidine, that is what I use because it is cheap, 27 rupees. So you give some clonidine to decrease the match of agents. Alpha 2 agonist interactions, clonidine or dexmed with opioids, dexmed with benzodiazepines, dexmed with agents. All these things are possible in the additive way. Buprenorphine and morphine, we know agonist and antagonist. There may be three-way interactions. See here, now the red is only propofol. The dose needed for unresponsiveness is the graph is here. Now green is propofol plus narcotic. Now the blue is propofol plus midazolam. And now this is propofol, midazolam, and fentanyl. If you give both the drugs and give propofol, your dose proportion and responsive is going to be here. You can see 0.2 or 0.3 milligrams per kg rather than 1 milligram per kg. This is pharmacodynamic interaction. There is no pharmaceutical. There is no pharmacokinetic. Herbal agents and opioids is a separate topic. Now we go to adrenaline and local anesthetic. Cleanly look. Adrenaline will prevent local anesthetic absorption. This is pharmacokinetic. Adrenaline will also is an alpha 2 agonist, like clonidine. So there it is pharmacodynamic. Add adrenaline and local anesthetic. There are pharmacokinetic and pharmacodynamic interactions. Now you see bupivacaine, even a one drop will make it precipitation. But lignocaine, even with 2 drops, it is okay. But when you add 2 ml, it becomes precipitate. So this is a pharmacoceutical interaction. This becomes form because before the injection. Now, here, if bupivacaine increases absorption by decreasing by pH change, that is a pharmacokinetic. So precipitation is pharmaceutical, and absorption increases pharmacokinetic. Pethidine and promethazine. That's what many people use those days. Pethidine, it causes sedation, but there is some pain decreasing effect of promethazine. Antagonistic effect. So this is a pharmacodynamic interactions. Midazolam decreases the production of norfentanyl by almost 95%, more hypotension, more bradycardia. Mixtures of local anesthetics. Fentanyl and bupivacaine for spinal. We don't know what is happening because when fentanyl is added, the baricity changes. If you add 1 ml to 1 ml of fentanyl, the baricity changes. There is a pharmaceutical interaction, something happening here, and then you inject fentanyl causes some more problems. That is pharmacodynamic. Myopyrite, tramadol, and ondansetron. Tramadol acts by also by 5-HT3. Ondansetron is also like that. Effect of tramadol on the depth of anesthesia. Tramadol excites. It's a very important thing. If you give tramadol, the MAC will decrease. So tramadol excites. You need to have more inhalation agents. The effect of ondansetron on the efficacy of postoperative tramadol. Yes, this is the most important thing I want to tell. Because if you give tramadol, patient may vomit. And if you give ondansetron, this vomiting will come down. But it will pain relief will also come down. That is what I'm under stress. If you give tramadol, patients may vomit. If you give ondansetron, vomiting will also decrease, anesthesia will also decrease. So it's very difficult to remember so many interactions. So you can have packet books or Googles or whatever it is. So you should know what is the drug interactions, pharmaceutical, pharmacokinetic, and pharmacodynamic. Examples like adrenaline, local anesthetics, which are pharmacokinetic and dynamic, or pharmaceutical dynamic like soda bicarb and local anesthetics.